Hi, everybody. Welcome back. Thanks so much for coming along. If you can see me and see the slides and see Joe, then just put a message in the chat, say yes or a thumbs up or something. That'd be really helpful. So hopefully we're actually going out to you. Can you see and hear us? Yep, brilliant. Thank you so much. Well, welcome. So we're going to be talking about mental health today. As ever, we'll just give it a few minutes for some more people to come in. Couple of things to flag, as always. There'll be a feedback link at the end. There's a QR code on the end of the slides, and I'll send a link in the chat as well for the feedback form. It'd be really, really helpful if you could fill this one out. And then when you do fill it out, you get an attendance certificate as well. And then the other thing to flag is the next session. So the next session is the session on dermatology, which was cancelled towards the end of February, unfortunately. We had to postpone it. So all being well, it will be next Wednesday. But there's a chance that it won't be, I'm afraid. It's a bit up in the air still, the date. But I will send the link in the chat to register. And if you do, then when we have a firm date or if it changes, you'll get notified. And so you'll know when it is. And obviously, I'll advertise in the same ways as I have previously. There'll be links on the Mind the Bleak Facebook page and links going out to the resident doctor group chats. So definitely keep an eye out for the date of that one. But I'll send the link over now. And yeah, you can register in advance and then you'll be able to see exactly when it will be. Yeah. Hopefully, again, if it's not next Wednesday, hopefully the Wednesday after, so we can keep the same kind of timing, Wednesdays 8 till 9. Yeah, cool. That's gone in the chat. So as I say, I'll just give it a minute or two. We'll let a few more people join and then we'll get started. Okay. Okay, let's get going then. I'm going to turn off my camera and my microphone and I'll hand over to you, Joe. Thanks so much.
Thanks, and thanks everyone for coming. It's a really important topic. So I'm glad to see some people have given up their Wednesday evening to come and join us. I know you can't talk, but if anyone has any questions, please just put them in the chat and I'll answer as best as I can. I haven't got any kind of questions for the audience as we go along, but it would be really interesting if anyone has any discussion points or anything that we can engage with that. So yeah, let's begin. It's a really interesting topic because there's obviously been a very difficult history between psychiatry and the LGBTQ plus community, with lots of hostility between the two, and it's important to acknowledge that, and it's also important to acknowledge that there needs to be a better relationship at the moment because there is such a high prevalence of mental illness in the community. So I'm going to discuss both the history and where we're at now, as well as the evidence behind there being an increased incidence of mental illness in the LGBTQ community, and then why that might be. What are the causes of this mental ill health in queer people? And then how can we tackle these problems and move towards a better future? So again, like I said, if you have any questions, put them in the chat, and if there are any problems, you can't hear me speak, the slides aren't working, again, let me know. Thanks so much. So first, talking about the history, like I said, it's important to acknowledge there's been this hostility to same-sex attraction that's been documented for centuries, since the 12th century. And I think it's particularly important to think about here as how illness and disease doesn't exist in a vacuum, but instead within the context of a broader society. And so this is particularly true for mental illness, that what a society deems normal and what a society deems pathological is kind of where we get definitions of psychiatric illness and mental illness. But I think here is also, you kind of see that it's actually a bi-directional relationship, that what psychiatrists and doctors say is pathological can then affect how society treats people with those traits. So the homosexuality has been described as mental illness in the past. One of the first kind of official recordings is back in the 1800s, when Alison Simmons had this book of kind of sexual deviances, is what they called it. And it was described as a pathology that needed to be treated and that should be viewed as an illness. And this view really persisted for a very long time, until very recently. And so by defining it as pathology, by defining homosexuality as an illness, that kind of necessitates or it implies there should be a way, there's something to treat, there's something to cure. And this led to quite a few different attempts at treating homosexuality, which are often quite abhorrent, quite grotesque. So, for example, there are instances of them trying to cure gayness by transplanting the testicles of a heterosexual man to a homosexual man in an attempt to change their sexuality. There's not much kind of scientific understanding of why this would work, but and also transplanting testicles would be very difficult because they're immunoprivileged anyway, and so the risks with regards to rejection and things like that are higher. Anyway, and this didn't work, obviously, but was extremely traumatic for patients involved. Similarly, you may have heard of conversion therapy, and at the time this was also called apomorphine therapy or aversion therapy. And essentially what this involved was showing gay men, and it was primarily men, and this was because it was illegal to be a gay man, whereas it wasn't illegal to be homosexual as a woman. So you would get gay men coming to doctors, to psychiatrists, to be treated for being gay because they didn't want to be arrested for it, for example. So as well as like kind of societal pressure and thinking that it's wrong and sinful and all those things. So you get these treatments such as apomorphine therapy. And so what happened was they would show you images or describe images of things that would be kind of sexually exciting to a homosexual man, and then give you an injection of apomorphine, which would induce nausea and vomiting. Or with aversion therapy, they would give you electric shocks. And the idea is that you kind of create this Pavlovian conditioning where they turn away from homosexual desires because their body is rejecting it, because it associates it with pain or nausea. And similarly, there's this thing called covert sensitization, which is where they would, it was a form of therapy where they would get you to, they would describe to the patient a sexual scene that was kind of sexually gratifying. So kind of if you begin having sex with a man and then suddenly introduce very grotesque images, like saying that his penis was rotting or that there were maggots crawling all over you, and try to associate kind of distaste and displeasure with the homosexual acts, so that you would move away from it. This is kind of clearly awful and kind of very disturbing to think about. It was obviously very traumatic for the patients, and not only was it incredibly traumatic, it didn't work. Like if the idea was to make people heterosexual, it didn't work, because all it did was traumatize them so much that they kind of had PTSD and wouldn't be able to engage in homosexual sex, and wouldn't have those, or would have those desires, and then would also have all the associated traumatic feelings. But that wouldn't make them heterosexual, because that's just not how sexuality works. It also, this led to increased prevalence of mental illness in these people. They often became depressed, and many died from suicide afterwards, as well as there being kind of direct mortality from aspiration pneumonia and things like that from the apomorphine treatment. So incredibly awful treatments for homosexuality. And so, because the combination of the idea that these treatments were so damaging, and that was justified because it was seen as pathology, but also because by seeing homosexuality as a pathology, you stopped it being normal and you stopped it being accepted. There was a big movement to try and declassify it as a disease. So they were following the Stonewall riots in '69. There were riots at the convention of the American Psychiatric Association, and there were lots of petitions kind of for many years, and to get it removed from the Diagnostic and Statistical Manual, which was used to diagnose mental illness. And then eventually in '63, it was officially removed, which was great. And I think it was really interesting to see the power that doctors and psychiatrists have in shifting what society sees as normal, and it is important for us to appreciate that as doctors, that what we say has such an influence on society, and to remember that it's not being affected by society, but that we affect society ourselves. So yes, it was removed as a pathology in '73, but it wasn't removed from the ICD, which is what we use in the UK, until 1990, which again is incredibly recent, really. Yeah. So, and I was talking a lot about homosexuality there, but it's also important to think about trans community. So I've just said that it was removed from the DSM. Homosexuality was removed from the DSM in '73, but then in the DSM-3, which came out in 1980, you had this first, you first see transsexualism, and again, this was a diagnosis that existed in the context of discrimination and prejudice against the trans community and trans individuals, and it's important for us to think about what effect did this have by introducing this as a pathology, and what effect does it have now? So they have now in the DSM-5 changed it from transsexualism to gender dysphoria, and on the APA website, it's very clear to stress that being transgender or gender non-conforming is not a pathology, but they do want to stress that the gender variance is just a variation, part of natural variation, but it's kept in the DSM to allow patients to access care, which is something that's needed in the trans community, but not in the homosexual community. So can maybe understand why there is that difference in in one being a DSM while the other's not. Yeah, and then it's important to think about that today. So the ICD-11, which has just come out, this is very recent. Again, this has been, it now classifies transsexualism as gender incongruence, and it's been moved into a new chapter, which is separate from the mental and behavioural disorders chapter, and is now in the conditions related to sexual health. So this is again a move to show that it's not a pathology, but is there to allow patients or individuals to access the care they need. However, unfortunately, conversion therapy, which we talked about before, is still somehow legal in the UK. Labour say they're going to ban it, but they haven't yet, as far as I'm aware. Similarly, in America, with all that's going on there, it's not illegal, like on a federal level. It's illegal in fewer than half the states. But the Supreme Court has recently accepted to hear a challenge from in Colorado about their conversion therapy ban, because there's a person arguing that it's a violation of their freedom of speech. And as we know, the current Supreme Court is overwhelmingly conservative, and it can be extremely damaging if they find that it is kind of unconstitutional to ban conversion therapy, because that could mean that they have to repeal bans in the states. But this is incredibly recent. You can't see this BBC article is from March of this year, so it is like literally 10 days ago, I think, or something like that. So yeah, worrying times. And part of the reason people justified that being queer, being part of the LGBTQ plus community was a pathology is because there's a high instance of other psychiatric pathologies in that community. And you can see this today, that there is still this increased prevalence. So there's a much higher percentage of symptoms of anxiety and depression in queer people. This is from these stats are taken from the Trevor Report, which is a survey that goes out. It's from America, and it's kind of national, and it looks at the mental health of queer people. And as you can see, there's really high rates of suicide, of anxiety and depression, and then if we go to the next slide, there's actually, if you look at all types of illness, there are increases in the community. So we've spoken about depression and anxiety, but also self-harm and suicidality are much higher compared to straight and cis. Similarly, half the men who are diagnosed with an eating disorder identify as part of the LGBTQ plus community, which is a really shocking statistic. And all members of the community are at increased vulnerability to eating disorders. The people, LGBTQ plus people, are more likely to suffer substance abuse, including alcohol abuse, which is particularly high among bisexuals, among the LGBTQ plus community, even compared to the L and the G, the B they're much more likely to suffer from alcohol-related issues. Similarly, LGBTQ plus people are more than twice as likely to develop PTSD, probably because they are much likely to experience trauma in their lives, which again, some really depressing stats there. And and I also wanted to touch on autism and the trans community, because one of our colleagues, Lorna Bowe, has done some really interesting work on the co-occurrence of autism in the trans community. It's around 11%, which compared to less than 2% in the general population. And so that's just something to be aware of, but it's important to recognize the impact of intersectionality, of the fact that being autistic comes with its own difficulties, and being part of the trans community, marginalized community, has its own difficulties. And then having both of those can create even more difficulties than each one individually. So it's important to recognize that, but also to recognize that autism in itself should not preclude gender-related care. This has been argued quite a few times in major newspapers, and it's not Lorna's article here kind of talks about how it's definitely shouldn't mean that you shouldn't be denied access. You shouldn't be denied access to gender-related care just because you also have or are autistic. So we've seen that there are increased prevalence of things like PTSD, depression and anxiety, eating disorders in the queer community. But why is that? And it's really important to recognize that it's not because these things are inherently pathological. Being gay is not mental illness. And I think this quote from Mama is really powerful. It highlights what we're about to talk about. That, and you can read it for yourself, but he's essentially saying that in a society which where there is kind of constant abuse and disparagement towards queer people, it would be amazing if there wasn't a high instance of mental illness and unhappiness, given the stigma. And it should not be said that this, what he calls neuroticism, but like mental illness, should be an intrinsic aspect of homosexuality, or indeed any part of the LGBTQ plus spectrum community. So this brings us to this idea of minority stress, and I know Lorna's touched on this in the introductory lecture, and it's a really helpful theory and framing to think about why queer people have an increased rate of mental illness. So it's from Maya, who developed in the kind of the 90s and then wrote this piece in early 2000s describing how being part of a stigmatized minority group brings with it a disharmony with your identity and the wider society. And this creates stresses every day. And stresses are things that can cause distress to you and cause an adaptive reaction, so that an attempt to kind of survive that stress. So these, in minority stress theory, these stresses are chronic, unique, and social. So importantly, that means the chronic side of it is that these are things that happen every day, constantly, from a very early age throughout life. You'll get these stresses multiple times a day. They're unique, so they are additive. They're not the normal stress of worrying about being late for work or whatever. It's kind of an additional stress on top of that you experience as someone who is queer or is part of a stigmatized minority group. Similarly, they're social stresses. These are things that are a product of the way society views that minority and the beliefs of that society and the culture that has arisen in that society. The minority stress theory further breaks it down within these three to being distal all the way to proximal. Okay, so distal stresses are objective stressful external life events, and these are acute and chronic. And these are things that anyone could see, and anyone could say, yeah, that's bad. I can see that's bad. This might be getting called a slur word. It might be being a victim of physical violence. It might be being denied a job because of your identity. And so these things are all very clearly bad and very clearly stresses. But then once you start to experience those stresses, you start to expect them. And with that expectation, you have an increased vigilance. So there's a lot of your energy goes into being more vigilant, and you begin to conceal your identity. And there's a stress associated with being constantly alert, constantly on the lookout, and also a stress of concealing your identity, of trying to be something you're not, and constantly self-censoring. A lot of energy goes into that, and it can be very distressing. And then at the most proximal level, you get this internalization of the negative societal attitudes. So if you're constantly told that you're lesser, that you're immoral, that you're mentally ill, these things become internalized. I think we've all heard of internalized homophobia, and that's kind of true of all the things that go on in all the stresses that we experience as part of the queer community. And this isn't necessarily conscious. It's often unconscious, and it's something that is kind of almost is built into your the way you see yourself, your self-image, from a very early age, just because of the way the whole of society acts, and tells you the way things are. And so Maya uses this very helpful diagram, which to explain minority stress, with disadvantaged status being linked to the circumstances of the environment. Circumstances in environment is essentially everyone has that they are the things that happen to everyone that create general stresses in life. But your disadvantaged status as a stigmatized minority produces its own stresses, and that's closely linked to the circumstances in the environment. And you can see here how that disadvantaged status leads to distal processes, stress events, which then are also linked to proximal stress events. And these can the general, distal, and the proximal stresses can all lead to health outcomes which are overwhelmingly negative. But interestingly, if you look, being part of a minority identity also brings with it a coping and social support on a community and individual level. The community, so there's lots of in-group cohesion, for example, within minority groups, and that can be protective against mental illnesses as well. And I think I wanted to bring up kind of the political environment, because I've been talking about how society constantly says there's lots of negativity in the environment towards the queer community, and this is just a few things that I wanted to bring up. For example, this is from the Trevor poll again that I mentioned earlier, with 90% of LGBTQ plus young people saying that their well-being was negatively impacted by recent politics, which is overwhelming. It's kind of but who can blame them? I mean, look at these are all recent headlines that I found like 2 days ago, with Hungary banning pride marches, Trump cancelling LGBTQ health health funds in America. And then all I'd had to do, I just typed in trans and then on the news tab on Google, and overwhelmingly it's these horrid stories about trans people being committing crimes and things like this. And there's just so much negativity and misinformation, and it's coming from all sides, and you can really see how how each of these things are both those distal objective stresses, but also can lead to those proximal stresses that would change the way you self-identify if you're met with this political environment day after day after day. Yeah, it's incredibly bleak. But on a slightly more positive note, there are some, being part of a minority group, which I have spoken about before, can lead to a sense of increased group solidarity and cohesiveness. Like I said, this is protective against mental illnesses, which Maya highlights is something that's is a good thing if you can use it to kind of help protect queer people's mental health. However, it's also highlighted that being in two different marginalized communities, for example, being Black and queer, can negate these ameliorating factors, because it's been shown that Black queer individuals will experience racism in the LGBTQ plus community, and then homophobia or transphobia in the Black community. And so they get that loss of in-group cohesiveness and that protection that it would have provided had they been only one part of only one marginalized group. And then interestingly, it may also explain why bisexuals are more likely to have mental illnesses like drug addiction or alcohol abuse compared to their homosexual peers, because there's some evidence showing that they're less accepted by the queer community, like they're less accepted into the homosexual community, but also not accepted into the straight community either. They're a minority that's kind of even more separated. Yeah, so it's important to think about these things, and it's important to think about these things. Why do we get this loss, this increased mental illness in the community? What causes it? And if we can understand what causes it, we can then use that to perhaps help treat to move towards a better place. So using minority stress theory, it helps focus and personalize care for these queer patients. So psychiatrists and therapists have specially designed therapy based on this theory to treat queer people with mental illness, and it's shown to be very effective. So two types of therapy that you can find online are called Esteem and Equip, both of which use the acronyms, and I can't remember them. They stand for, but they're both based on CBT, using minority stress theory to specifically personalize and target the mental illness in the queer community and in queer patients. And I also wanted to stress that even if you don't want to be a psychiatrist or a therapist, it's really important to recognize that your patients, you'll see patients who are gay, trans, and it's important to understand the difficulties they go through and why their mental health is likely to be worse. Why, unfortunately, having these things is a risk factor for worse mental health outcomes. And just appreciating that can make a big difference to patients, I think. So I just wanted to touch on how minority stress theory is used in Esteem. There are 6 key principles to it. Esteem is one of these specific therapies designed based on minority stress theory. So the first one is that these symptoms are, and they're normal. It's a normal reaction to these stresses that are unique to you as part of this minority, and that these stresses occurred early and they're ongoing, and they teach you very powerful and very negative lessons about yourself. But you can be empowered to cope effectively with these consequences. You shouldn't have to. It's not fair, but you can be taught to cope with them, and including using the benefits of in-group cohesion and things like that you get from being part of a minority. And similarly, that sexual minorities possess unique strengths that can empower them. It's also really important to emphasize to patients that same-sex sexuality is healthy. There's nothing pathological about it, but it's, despite what you might see in the media or might be told throughout your life, and that having a genuine relationships is important for everyone, and everyone's health, particularly those, or including those who are sexual minorities. And I thought that is quite interesting to think about those and how the theory is incorporated into the therapy. I also wanted to highlight that gender-affirming care, while maybe not direct psychiatric intervention, is very good at treating psychiatric illness. It saves lives. There's lots of studies showing that it reduces mental illness, reduces so gender-affirming care such as puberty blockers, gender-affirming hormones, surgery decreases depression, decreases suicidality, and increases quality of life. So it's very good at reducing mental illness. And there's I've seen a lot of talk in the media about how we shouldn't allow people to do it because they might regret it, etc. However, there's quite a lot of studies showing that the regret levels are really low, 1%, less than 1% actually, for gender-affirming surgery, whereas you compare that to something like knee arthroplasty, which we think is a pretty standard procedure, as high as 20% regret rate. I think that's a very powerful statistic, and quite revealing about the people who are scaremongering about gender-affirming surgery. And then I just wanted to touch on the policy implications that we can think about as healthcare providers, but also as voters and as people who are able to protest and interact with people every day. It's really, what we've seen is that stigma causes mental illness. So if we reduce stigma, we can reduce mental illness. And there are many levels that this can happen on. On the international level, we've seen that in America, they're moving back on rights for LGBTQ plus people. In Hungary, they are, but across the world that they are. And if we can join protests, support people who are fighting these laws, we can make a difference. And similarly, on a national level, we can vote for the people we think will promote the most, will promote the rights of the LGBTQ plus community. We can petition to remove barriers to gender-related care. On a regional level, you can do education. You can tell you can promote the ideas and that about reducing stigma and educating about LGBTQ plus issues. And on an institutional level, so in your hospitals, you can wear the rainbow lanyard, which shows patients and other providers in the institution that you are someone who is accepting and willing to kind of support them as support them if they are part of the LGBTQ plus community. And then on a personal level, you try not to be part of the problem, try to be part of the solution. As a healthcare provider, you can do so much to help your patients if you can understand and talk to them about the difficult things they've been through, and make an effort to engage with them on these things and try and make life better. You can make a real difference, but equally ignoring it can cause real harm. So remember, as with all patients and with all problems, it's important to take the context of their lives into account. It can make a real difference. So thank you all for listening to me on this evening. I hope it's been interesting. It's a really important topic. Thank you again for giving up your time. It's really nice that people have come. Thanks. And let me know if you have any questions.
Thanks so much, Joe. Yeah, guys, if there's any questions at all, do pop them in the chat. And there is the QR code for the feedback link. I had a question. I just thought on a really sort of tangible, like practical level. What would you say is the most practical thing we can do to like support the mental health of our LGBT patients as med students or as foundation doctors?
Great question. I think asking is really helpful. Just acknowledging that they might be struggling, that they might not know that it's that they might feel that they're alone and that they can't talk to anyone, but just acknowledging, asking how are they, I think is something that could be really helpful. And I mean, what do you think? Do you think there is anything that people would appreciate?
I think some of the things you were saying about making it clear that you're like a safe person, so like wearing the rainbow lanyard, for example, or like a rainbow pin is really helpful. And we spoke, I think, in a previous session about maybe if you're observing an interaction that isn't going so well, maybe a consultant with a patient and they're not kind of acting or saying the right things, then when that person has gone away, kind of if it feels appropriate, taking a moment to just express that you're sorry for the interaction they just had and that you kind of maybe don't understand, but you're sympathetic and like just flag up that you are somebody safe that they could talk to. It's go on.
I was thinking that I think that's really important, like you were saying, to stand up for the kind of against microaggressions and macroaggressions, and it's not uncommon to see things like that. And I think patients can feel really alone when because there's such a power imbalance between a patient and a consultant. You can help, you can really make a difference there. It's really good.
Yeah, definitely. I think a patient would potentially struggle to kind of speak up for themselves, especially if they're unwell. And in that kind of hospital environment or GP surgery, which like is the doctor's environment and not the patient's comfortable environment so much. I think another key thing as well when you're seeing patients with mental health problems is never to kind of put mental health issues down to their sexuality or their gender, etc. Because that can be a real issue for LGBT patients. Is they go about a mental health problem and it's just described as this because of this part of your identity, or in fact, like vice versa, being told that being this identity is going to make you depressed or give you anxiety. You can in fact have both or just one at a time if you like.
And I think maybe I should have emphasized that more, but this idea of madness is something that is a risk factor. It doesn't mean that it's definitely every patient who is queer is going to be mentally ill, and also that you're absolutely right that you shouldn't say to patients, you shouldn't kind of force that onto them that any mental illness is because of them being part of the LGBTQ community. Completely agree.
Exactly. Okay. Thank you so much. Looks like we don't have any other questions from people. I'm going to put the link in for the feedback form in case you'd rather click on a link and then scan the QR code. It might be easier. There we are. That should have gone. And then, yeah, our next session on dermatology, the link is in the chat if you just scroll up a little bit. Hopefully next week or the one after, but if you keep an eye out, then you'll see what date it will be. Okay. All right. Well, thank you so much, everybody. Thanks again, Joe. And yeah, I'll leave you all to get some food and dinner now. All right. Thanks so much.
Thanks. Bye, guys.
Bye. Bye.